In mammals, the vagina is a muscular and tubular part of the female genital tract, which, in humans, extends from the vulva to the cervix. The outer vaginal opening may be partly covered by a membrane called the hymen. At the deep end, the cervix, neck of the uterus, bulges into the vagina. The vagina allows for sexual intercourse and childbirth, and channels menstrual flow, which occurs periodically as part of the menstrual cycle. The vagina has been studied in humans more than it has been in other animals. Its location and structure varies among species, and may vary in size within the same species. Female mammals usually have two external openings, the urethral opening for the urinary tract and the vaginal opening for the genital tract. This is different to male mammals, who usually have a single opening, the external urethral opening for both urination and reproduction. The vaginal opening is much larger than the nearby urethral opening, and both are protected by the labia in humans. In amphibians, birds, reptiles, and monotremes, the cloaca is the single external opening for the gastrointestinal tract and the urinary and reproductive tracts. To accommodate smoother penetration of the vagina during sexual intercourse or other sexual activity, vaginal moisture increases during sexual arousal in human females and also in other female mammals. This increase in moisture is vaginal lubrication, which reduces friction. The texture of the vaginal walls creates friction for the penis during sexual intercourse and stimulates it toward ejaculation, enabling fertilization. Along with pleasure and bonding, women's sexual behavior with others, which can include heterosexual or lesbian sexual activity, can result in sexually transmitted infections, STIs, the risk of which can be reduced by recommended safe sex practices. Other disorders may also affect the human vagina. The vagina and vulva have evoked strong reactions in societies throughout history, including negative perceptions in language, cultural taboos, and their use as symbols for female sexuality, spirituality, or regeneration of life. In common speech, the word vagina is often used to refer to the vulva or to the female genitals in general. By its dictionary and anatomical definitions, however, vagina refers exclusively to the specific internal structure, and understanding the distinction can improve knowledge of the female genitalia and aid in healthcare communication. Etymology and definition. The term vagina is from Latin veni, literally sheath or scabbard. The Latinate plural of vagina is vaginae. The vagina may also be referred to as the birth canal in the context of pregnancy and childbirth. Although by its dictionary and anatomical definitions, the term vagina refers exclusively to the specific internal structure, it is colloquially used to refer to the vulva or to both the vagina and vulva. Using the term vagina to mean vulva can pose medical or legal confusion. For example, a person's interpretation of its location might not match another person's interpretation of the location. Medically, the vagina is the muscular canal between the hymen, or remnants of the hymen, and the cervix, while, legally, it begins at the vulva, between the labia. Scholars such as Craig A. Hill argue that incorrect use of the term vagina is likely because not as much thought goes into the anatomy of the female genitalia. This has contributed to an absence of correct vocabulary for the external female genitals, even among health professionals, which can pose sexual and psychological harm with regard to female development. Because of this, researchers endorse correct terminology for the vulva. Structure. Overview. The human vagina is an elastic muscular canal that extends from the vulva to the cervix. It is reddish-pink in color, and it connects the outer vulva to the cervix of the uterus. The part of the vagina surrounding the cervix is called the fornix. The opening of the vagina lies near the middle of the perineum, between the opening of the urethra and the anus. The vaginal canal then travels upwards and backwards, between the urethra at the front, and the rectum at the back. Near the upper vagina, the cervix protrudes into the vagina on its front surface at approximately a 90-degree angle. The vaginal and urethral openings are protected by the labia. In its unexcited state, the vagina is a collapsed tube, with the anterior and posterior walls placed together. The lateral walls, especially their middle area, are relatively more rigid. Because of this, the collapsed vagina has a H-shaped cross-section. Behind, the inner vagina is separated from the rectum by the recto-uterine pouch, the middle vagina by loose connective tissue, and the lower vagina by the perineal body. Where the vaginal lumen surrounds the cervix of the uterus, it is divided into 4 continuous regions or vaginal fornices. These are the anterior, posterior, right lateral, and left lateral fornices. The posterior fornix is deeper than the anterior fornix. Supporting the vagina are its upper third, middle third and lower third muscles and ligaments. The upper third are the levator ani muscles, transcervical, pubocervical, and the sacrocervical ligaments. These areas are also described as the cardinal ligaments laterally and uterosacral ligaments posterolaterally. The middle third of the vagina concerns the urogenital diaphragm, also described as the pericolpus and pelvic diaphragm. The lower third is the perineal body. It may be described as containing the perineal body, pelvic diaphragm, and urogenital diaphragm. Vaginal opening and hymen. The vaginal opening is at the outer end of the vulva, posterior to the opening of the urethra, at the posterior end of the vestibule. The opening is closed by the labia minora in female virgins and in females who have never given birth, nullipary, but may be exposed in females who have given birth, parous females. The hymen is a membrane of tissue that surrounds or partially covers the vaginal opening. The effects of vaginal intercourse and childbirth on the hymen are variable. If the hymen is sufficiently elastic, it may return to nearly its original condition. In other cases, there may be remnants, carunculi myrtiformes, or it may appear completely absent after repeated penetration. Additionally, the hymen may be lacerated by disease, injury, medical examination, masturbation, or physical exercise. For these reasons, it is not possible to definitively determine whether or not a girl or woman is a virgin by examining her hymen. Variations in size. The length of the vagina varies between women of childbearing age. Because of the presence of the cervix in the front wall of the vagina, there is a difference in length between the front, anterior, wall, approximately 7.5 centimeters, 2.5 to 3 in, long, and the back, posterior, wall, approximately 9 centimeters, 3.5 in, long. During sexual arousal, the vagina expands in both length and width. If a woman stands upright, the vaginal tube points in an upward-backward direction and forms an angle of approximately 45 degrees with the uterus and of about 60 degrees to the horizontal. The vaginal opening and hymen also vary in size. In children, although a common appearance of the hymen is crescent-shaped, many shapes are possible. Development. The vaginal plate is the precursor to the vagina. During development, the vaginal plate begins to grow where the solid ends of the parmesonephric ducts, Mullerian ducts, enter the back wall of the urogenital sinus. As the plate grows, it separates the sinus into the urethra and the vagina and extends the vagina by pushing the cervix deeper. Originally full of cells, as the central cells of the plate break down, the lumen of the vagina is formed. This usually occurs by the 20 to 24th week of development. If the lumen does not form, or is incomplete, membranes across or around the tract called septae can form, which may cause obstruction of the outflow tract later in life. During sexual differentiation of females, without testosterone, the urogenital sinus persists as the vestibule of the vagina. The two urogenital folds, elongated spindle-shaped structures that contribute to the formation of the urethral groove on the belly aspect of the genital tubercle, form the labia minora, and the labioscrotal swellings enlarge to form the labia majora. There is debate as to which portion of the vagina is formed from the Mullerian ducts and which from the urogenital sinus by the growth of the sinovaginal bulb. Dedworth's textbook of obstetrics and gynecology states, some believe that the upper 4/5 of the vagina is formed by the Mullerian duct and the lower 1/5 by the urogenital sinus, while others believe that sinus upgrowth extends to the cervix displacing the Mullerian component completely and the vagina is thus derived wholly from the endoderm of the urogenital sinus. It adds, it seems certain that some of the vagina is derived from the urogenital sinus, but it has not been determined whether or not the Mullerian component is involved. Microanatomy. The wall of the vagina from the lumen outwards consists firstly of a mucosa of non-keratinized stratified squamous epithelium with an underlying lamina propria of connective tissue, secondly a layer of smooth muscle with bundles of circular fibers internal to longitudinal fibers, and thirdly an outer layer of connective tissue called the adventitia. Some texts list 4 layers by counting the 2 sublayers of the mucosa, epithelium and lamina propria, separately. The lamina propria is rich in blood vessels and lymphatic channels. The muscular layer is composed of smooth muscle fibers, with an outer layer of longitudinal muscle, an inner layer of circular muscle, and oblique muscle fibers between. The outer layer, the adventitia, is a thin dense layer of connective tissue, and it blends with loose connective tissue containing blood vessels, lymphatic vessels, and nerve fibers that is present between the pelvic organs. The mucosa forms folds or rugae, which are more prominent in the outer third of the vagina. They appear as transverse ridges and their function is to provide the vagina with increased surface area for extension and stretching. The epithelial covering of the cervix is continuous with the epithelial lining of the vagina. The vaginal mucosa is absent of glands. The vaginal epithelium consists of 3 rather arbitrary layers of cells: superficial flat cells, intermediate cells, and basal cells, and estrogen induces the intermediate and superficial cells to fill with glycogen. The superficial cells exfoliate continuously and basal cells replace them. Under the influence of maternal estrogen, newborn females have a thick stratified squamous epithelium for 2 to 4 weeks after birth. After that, the epithelium remains thin with only a few layers of cells without glycogen until puberty, when the epithelium thickens and glycogen-containing cells are formed again, under the influence of the girl's rising estrogen levels. Finally, the epithelium thins out during menopause onward and eventually ceases to contain glycogen, because of the lack of estrogen. In abnormal circumstances, such as in pelvic organ prolapse, the vaginal epithelium may be exposed, becoming dry and keratinized. Blood and nerve supply. Blood is mainly supplied to the vagina via the vaginal artery, which emerges from a branch of the internal iliac artery or the uterine artery. With anastomosis, the vaginal arteries are joined along the side of the vagina with the cervical branch of the uterine artery. This forms the ezygous artery, which lies on the midline of the anterior and posterior vagina. Other arteries which supply the vagina include the middle rectal artery and the internal pudendal artery, all branches of the internal iliac artery. 3 groups of lymphatic vessels accompany these arteries. The upper group accompanies the vaginal branches of the uterine artery, a middle group accompanies the vaginal arteries, and the lower group, draining lymph from the area outside the hymen, drain to the inguinal lymph nodes. Nerve endings in the vagina can provide pleasurable sensations when the vagina is stimulated during sexual activity. Women may derive pleasure from one part of the vagina, or from a feeling of closeness and fullness during vaginal penetration. The vagina is not rich in nerve endings, and this often contributes to a woman's inability to receive sufficient sexual stimulation, including orgasm, solely from penetration of the vagina. While the literature cites the existence of a greater concentration of nerve endings near the entrance of the vagina, at the outer 1/3 or lower third, making it more sensitive to touch than the inner, or upper, 2/3 of the vagina, some scientific examinations of vaginal wall innervation indicate no single area with a greater density of nerve endings. Other research indicates that only some women have a greater density of nerve endings in the anterior vaginal wall. By having a higher concentration of nerve endings in the outer part rather than along the whole length, childbirth pain is significantly more tolerable. Vaginal pleasure can come from a variety of different sexual activities. In addition to penile penetration, pleasure may be by masturbation, fingering, oral sex, cunnilingus, or specific sex positions, such as the missionary position or the spoon sex position. Heterosexual couples may engage in cunnilingus or fingering as forms of foreplay to incite sexual arousal, with penile vaginal penetration as the primary sexual activity, or they may engage in them in addition to penile vaginal penetration. In other cases, heterosexual couples use the latter acts as a way to preserve virginity or as a type of birth control. By contrast, lesbians and other women who have sex with women commonly engage in cunnilingus or fingering as main forms of sexual activity. Some women and couples use sex toys, such as a vibrator or dildo, for vaginal pleasure. Other women may adopt Kegel exercises, with the aim of tightening the vagina to increase sexual pleasure. The Kama Sutra, an ancient Hindu text written by Vatsayana, which includes a number of sexual positions, may also be used to increase sexual pleasure, with special emphasis on female sexual satisfaction. The clitoris additionally plays a part in vaginal stimulation, as it is a sex organ of multiplanar structure containing an abundance of nerve endings, with a broad attachment to the pubic arch and extensive supporting tissue to the mons pubis and labia. It is centrally attached to the urethra, and research indicates that it forms a tissue cluster with the vagina. This tissue is perhaps more extensive in some women than in others, which may contribute to orgasms experienced vaginally. During sexual arousal, and particularly the stimulation of the clitoris, the walls of the vagina lubricate. This begins after 10 to 30 seconds of sexual arousal, and increases in amount the longer the woman is aroused. It reduces friction or injury that can be caused by insertion of the penis into the vagina or other penetration of the vagina during sexual activity. The vagina lengthens during the arousal, and can continue to lengthen in response to pressure. As the woman becomes fully aroused, the vagina expands in length and width, while the cervix retracts. With the upper two-thirds of the vagina expanding and lengthening, the uterus rises into the greater pelvis, and the cervix is elevated above the vaginal floor, resulting in tenting of the mid-vaginal plane. This is known as the tenting or ballooning effect. As the elastic walls of the vagina stretch or contract, with support from the pelvic muscles, to wrap around the inserted penis, or other object, this stimulates the penis and helps to cause a man to experience orgasm and ejaculation, which in turn enables fertilization. An area in the vagina that may be an erogenous zone is the G-spot, also known as the Grafenberg spot. It is typically defined as being located at the anterior wall of the vagina, a couple or few inches in from the entrance, and some women experience intense pleasure, and sometimes an orgasm, if this area is stimulated during sexual activity. A G-spot orgasm may be responsible for female ejaculation, leading some doctors and researchers to believe that G-spot pleasure comes from the Skene's glands, a female homologue of the prostate, rather than any particular spot on the vaginal wall. Other researchers consider the connection between the Skene's glands and the G-spot area to be weak. The G-spot's existence, and existence as a distinct structure, is still under dispute, as its reported location can vary from woman to woman, appears to be non-existent in some women, and it is hypothesized to be an extension of the clitoris and therefore the reason for orgasms experienced vaginally. Childbirth. Two main veins drain blood from the vagina, one on the left and one on the right. These form a network of smaller veins, an anastomosis, on the sides of the vagina, connecting with similar networks of the uterine, vesical, and rectal networks. These ultimately drain into the internal iliac veins. The nerve supply of the upper vagina is provided by the sympathetic and parasympathetic areas of the pelvic plexus. The lower vagina is supplied by the pudendal nerve supplying the lower area. Function. Secretions. The vagina provides a path for menstrual blood and tissue to leave the body. In industrial societies, tampons, menstrual cups, and sanitary napkins may be used to absorb or capture these fluids. Vaginal secretions are primarily from the uterus, cervix, and vaginal epithelium in addition to minuscule vaginal lubrication from the Bartholin's glands upon sexual arousal. It takes little vaginal secretion to make the vagina moist. Secretions may increase during sexual arousal, the middle of menstruation, a little prior to menstruation, or during pregnancy. The Bartholin's glands, located near the vaginal opening, were originally considered the primary source for vaginal lubrication, but further examination showed that they provide only a few drops of mucus. The significant majority of vaginal lubrication is now believed to be provided by plasma seepage from the vaginal walls, which is called vaginal transudation. Vaginal transudation, which initially forms as sweat-like droplets, is caused by vascular engorgement of the vagina, vasocongestion, resulting in the pressure inside the capillaries increasing the transudation of plasma through the vaginal epithelium. Before and during ovulation, the mucus glands within the cervix secrete different variations of mucus, which provides an alkaline, fertile environment in the vaginal canal that is favorable to the survival of sperm. As women age, especially following menopause, vaginal lubrication naturally decreases. Sexual activity. The vagina provides a channel to deliver a newborn to its independent life outside the body of the mother. When childbirth, or labor, nears, several symptoms may occur, including Braxton Hicks contractions, vaginal discharge, and the rupture of membranes and resulting gush of amniotic fluid through the vagina, also known as water breaking. When water breaking happens, there may be an uncommon wet sensation in the vagina. This could be an irregular or small stream of fluid from the vagina, or a gush of fluid. When the body prepares for childbirth, the cervix softens, thins, moves forward to face the front, and may begin to open. This allows the fetus to settle or drop into the pelvis. When the fetus settles into the pelvis, this may result in pain in the sciatic nerves, increased vaginal discharge, and increased urinary frequency. While these symptoms are likelier to happen after labor has already begun for women who have given birth before, they may happen approximately 10 to 14 days before labor in women experiencing the effects of nearing labor for the first time. The fetus begins to lose the support of the cervix when uterine contractions begin. With cervical dilation reaching a diameter of more than 10 cm, 4 in, to accommodate the head of the fetus, the head moves from the uterus to the vagina. The elasticity of the vagina allows it to stretch to many times its normal diameter in order to deliver the child. Injections for pain control during childbirth is often administered through the vaginal wall and near the pudendal nerve. This nerve carries sensations to the lower part of the vagina and vulva. This is only used late in labor, usually right before the baby's head comes out. With a pudendal block, there is some relief from the pain and the laboring woman remains awake, alert, and able to push the baby out. The baby is not affected by this medicine and it has very few disadvantages. Vaginal births are more common, but there are sometimes complications and a woman might undergo a cesarean section, commonly known as a C-section, instead of a vaginal delivery. The vaginal mucosa has an abnormal accumulation of fluid, edematous, and is thin, with few rugae, a little after birth. The mucosa thickens and rugae return in approximately 3 weeks once the ovaries regain usual function and estrogen flow is restored. The vaginal opening gapes and is relaxed, until it returns to its approximate pre-pregnant state by 6 to 8 weeks in the period beginning immediately after the birth, the postpartum period, however, it will maintain a larger shape than it previously had. Vaginal microbiota. The vagina is a complex ecosystem that undergoes long-term changes, from neonate to puberty and from menarche to menopause. Healthy vaginal microbiota consists of species and genera which generally do not cause symptoms, infections, result in good pregnancy outcomes, and is dominated mainly by lactobacillus species. Under the influence of hormones, such as estrogen, progesterone, and follicle-stimulating hormone, FSH, the vaginal ecosystem undergoes cyclic or periodic changes. Clinical significance. General. The vagina is self-cleansing and therefore usually does not need special hygiene. Doctors generally discourage the practice of douching for maintaining vulvovaginal health. Since a healthy vagina is colonized by a mutually symbiotic flora of microorganisms that protect its host from disease-causing microbes, any attempt to upset this balance may cause many undesirable outcomes, including abnormal discharge and yeast infection. The vagina and cervix are examined during gynecological examinations of the pelvis, often using a speculum, which holds the vagina open for visual inspection or taking samples. See Pap smear. This and other medical procedures involving the vagina, including digital internal examinations and administration of medicine, are referred to as being per vaginam, the Latin for via the vagina, often abbreviated to P.V. Examination of the vagina may also be done during a cavity search. The healthy vagina of a woman of childbearing age is acidic, with a pH normally ranging between 3.8 and 4.5, this is due to the degradation of glycogen to the lactic acid by enzymes secreted by the Doederlein's bacillus, which is a normal commensal of the vagina. The acidity delays or slows the growth of many strains of pathogenic microbes. An increased pH of the vagina, with the commonly used cutoff of pH 4.5 or higher, can be caused by bacterial overgrowth, as occurs in bacterial vaginosis and trichomoniasis, or rupture of membranes in pregnancy. There are different types of bacterial vaginosis. Intravaginal administration is a route of administration where the substance is applied to the inside of the vagina. Pharmacologically, it has the potential advantage to result in effects primarily in the vagina or nearby structures, such as the vaginal portion of cervix, with limited systemic adverse effects compared to other routes of administration. Effects of aging and childbirth. Average vaginal pH varies significantly during a woman's lifespan, from 7.0 in premenarchal girls, to 3.8 to 4.4 in women of reproductive age, to 6.5 to 7.0 during menopause without hormone therapy, and 4.5 to 5.0 with hormone replacement therapy, HRT. Estrogen, glycogen, and lactobacilli are important factors in this variation. After menopause, the body produces less estrogen, which causes the vaginal walls to thin out significantly. The effects of menopause can lead to vaginal dryness, due to a decrease in vaginal lubrication, which causes vaginal discomfort on its own or discomfort or pain during sexual intercourse. This can be alleviated with hormone replacement therapy, estrogen-containing vaginal creams, or non-prescription, non-hormonal products, but there are risks and adverse effects associated with hormone replacement therapy. Some women have an increase in sexual desire following menopause. Masters and Johnson's research indicates that menopausal women who continue to engage in sexual activity regularly experience vaginal lubrication similar to levels in women who have not entered menopause, and can enjoy sexual intercourse fully. Vaginal changes that happen with aging and childbirth include mucosal redundancy, rounding of the posterior aspect of the vagina with shortening of the distance from the distal end of the anal canal to the vaginal opening, diastasis, or disruption of the pubicoccygis muscles caused by poor repair of an episiotomy, and blebs that may protrude beyond the area of the vaginal opening. Other vaginal changes related to aging and childbirth are urinary incontinence, rectocele, cystocele, and stress. Similar vaginal and labial changes may be due to significant weight gain and subsequent loss. Infections, safe sex, and disorders. There are many infections, diseases, and disorders that can affect the vagina, including candidal vulvovaginitis, vaginitis, vaginismus, sexually transmitted infections, STIs, or cancer. Vaginitis is an inflammation of the vagina, and is attributed to several vaginal diseases, while vaginismus is an involuntary tightening of the vagina muscles caused by a conditioned reflex, or disease, during vaginal penetration. HIV/AIDS, human papillomavirus, HPV, genital herpes, and trichomoniasis are some of the STIs that may affect the vagina, and health sources recommend safe sex, or barrier method, practices to prevent the transmission of these and other STIs. Safe sex commonly involves the use of condoms, also known as male condoms, but female condoms, which give women more control during the safe sex practice, may also be used. Both condoms keep semen from coming in contact with the vagina, which can also help prevent unwanted pregnancy. There is, however, little research on whether female condoms are as effective as male condoms at preventing STIs, and they are slightly less effective than male condoms at preventing pregnancy, which may be due to the female condom not fitting as tightly as the male condom or because it can slip into the vagina and spill semen. Cervical cancer may be prevented by pap smear screening and HPV vaccines. Vaginal cancer is very rare, and is primarily a matter of old age. Its symptoms include abnormal vaginal bleeding or vaginal discharge. There can be a vaginal obstruction, such as one caused by agenesis, an imperforate hymen or, less commonly, a transverse vaginal septum. These cases require differentiation because surgery for them significantly varies. When there is a lump obstructing the vaginal opening, it is likely a Bartholin's cyst. Vaginal prolapse is characterized by a portion of the vaginal canal protruding, prolapsing, from the opening of the vagina. It may result in the case of weakened pelvic muscles, which is a common result of childbirth. In the case of this prolapse, the rectum, uterus, or bladder pushes on the vagina, and severe cases result in the vagina protruding out of the body. Kegel exercises have been used to strengthen the pelvic floor, and may help prevent or remedy vaginal prolapse. Modification. The vagina, including the vaginal opening, may be altered as a result of genital modification during vaginoplasty or labiaplasty. Those who undergo vaginoplasty are usually older and have given birth to one or more children. A thorough examination of the vagina before a vaginoplasty is standard, as well as being referred to a urogynecologist for possible vaginal disorders. With regard to labiaplasty, reduction of the labia minora is quick without hindrance, and any complications are rare and can be corrected. The complications are minor enough that those with them may still be satisfied with the procedure. Any scarring from the procedure is minimal, and long-term chronic problems have not been identified. There is no evidence that such surgery improves psychological or relationship problems. However, the surgery has a risk of damaging blood vessels and nerves. Female genital mutilation, FGM, another aspect of female genital modification, may additionally be known as female circumcision or female genital cutting, FGC. FGM has no known health benefits. The most severe form of FGM is infibulation, in which there is removal of all or part of the inner and outer labia, labia minora and labia majora, and the closure of the vagina. This is called type 3 FGM, and it involves a small hole being left for the passage of urine and menstrual blood, with the vagina being opened up for sexual intercourse and childbirth. Society and culture. Perceptions, symbolism, and vulgarity. Various perceptions of the vagina have existed throughout history, including the belief it is the center of sexual desire, a metaphor for life via birth, inferior to the penis, unappealing to s.
Please subscribe and thanks for watching.